with us. Dr. Licht is a pediatric nephrologist in Sickkids Hospital in Toronto. He is a well-known researcher in complement diseases, which aHUS is one of them. And we welcome Dr. Licht here this morning, and hope you enjoy his presentation. So welcome, Dr. Licht.
Thank you very much, Margaret, for the introduction and the welcome. And thank you for the invitation to being with you, both actually last night at the dinner and this morning at the session. Both my wife and myself, we enjoyed ourselves a lot last night. And especially my wife was impressed by what you guys are doing, and also by what you were going through and are going through. So that's my first point actually this morning. I really want to commend you. I think you have come a long, long way. There's you thank people coming here to present, but at the same time, I have to come here to thank you for what you are doing. We just recently diagnosed a new patient, and I shared it with somebody over coffee last night. It's one thing to then explain a disease and share professional aspects, but it's another thing to realize, there's so much more that you can't talk about at this moment, but that has to be addressed. And the people who are really in the best position to doing that is you, who have experienced and lived through this diagnosis and all the uncertainties and all the ups and downs, and can share, can understand what this new patient and family is going through, and can also share, the perspectives. So this is priceless, and I am not fishing for compliments here. This is an amazing contribution to managing, not only your own problems, but the problems of everybody else who is sharing this diagnosis. So thank you very much for that, and keep going. And I'm committing to supporting you as much as I can moving forward. All right. So I don't know what I'm going to do this morning, but I promised myself to make this as low-key and interactive as possible. First is I'm not going to the podium. I hope you can hear my voice, so I'm trying to speak up, and if you can't hear me, or if I'm saying things that you don't understand or you don't want me to talk about, then you need to stop me or let me know. The second is please interrupt for questions. I think this is the best use of this time. I have a talk that I can present back and forth to you if you want that. Not that I'm perfect with the talk, but I can just do the slides. But I think it's much better to use the slides to, in a focused way, but really be guided by what you want to hear. I start with the slides, but then I hope that we deviate from them. So the first thing that I wanted to, or the starting point of this, the slide set is this picture. Does anybody dare to tell me what this is? Yes. What is it? I hear the word glomerulus or glomeruli. You said?
The membrane of the glomerulus?
The glomerulus. Uh-huh. What did you want to say? It's not two kidneys, but it's one little piece of tissue from one kidney. Okay? If you would do a biopsy and the pathologist would take a look under the microscope, exactly. So I'm starting with a kidney. So this is the kidney, this is the ureter, that's where the pee goes. Then there's two sets of vessels going in, artery, vein, and then you have kind of an inner space that's called the pelvis of the kidney. And then you have this outer rim that's called the cortex of the kidney. And in this, and you have obviously two of those kidneys, but I'm just kind of showing one. And within this cortex, this area, you have these little units. And you have many of those. You have several hundred thousands altogether, close to 1 million between both kidneys. And that's really that's the backbone of what a kidney does. It filters blood to produce urine, to clean your blood. And those bodies called glomeruli, and I'm showing two back to or side to side. So this is one. Can you see it? And this is the other one. Those units are sitting here. So that's where those two little blips could be sitting. And again, you have about, a total of 1 million of those in between both kidneys. Sure. And the job of those, as I said already, the job of those bodies, they look like a wine glass, if you want. They accept blood vessels that are coiled up inside and then leave this spheric structure again. So this is a cut through, but if you took a three-dimensional picture of that, it would be a sphere, right? With an opening, blood vessels go in, coil up, go out. And across the membrane or the wall of these little coiled up blood vessels, the blood is filtered. That's where the kidney does its job. 100,000 times, 1 million times in between both kidneys. And then urine is produced and kind of collected in little tubes, and the urine is processed. We won't talk about that since that's not our topic for today. And these little open spaces are sections through those tubes. Okay, so that's how this is a kidney. You have the filter units here, and you have those structures like the little tubules, and they're kind of going back and forth. That's why you have many of those side to side. But that's really where these filter units collect and process the urine. Okay, so this is how this is a kidney. Now, I won't ask you what's abnormal here. I'm telling you that this filter unit, this glomerulus, as it's called, should be less. There should be less blue, right, and less red. And the reason for this here being, heavier in staining, is that it is all these small blood vessels that are coiled up are not open, and blood can stream through. And at the moment you take a biopsy and you stain it, you would just see white open spaces. This kidney has clots in it, right? It's filled with mini clots, and those spaces, those blood vessels that should be wide open, are clogged. So this is a biopsy from a patient with atypical aHUS. Okay, so this is what the disease really is about. It's a clogging of those filter units in the kidney and the clogging happens by the formation of blood clots. All right?
Can I interrupt?
Sure, please.
So the red and the very dark blue is all clots.
Yeah, so for the purpose of this presentation, yes, the answer is yes. I mean, there are subtleties to the staining and so on, but that's what I want to show exactly.
And is this typical of patients with renal failure?
So that's a good question leading to the next point. So far I have only described how it should be and the situation in terms of presence of blood clots in a kidney of a patient with aHUS. there's a problem with the presence of those clots. In areas where clots are clogging the small vessels, blood cannot go through anymore. And with that, you have areas in the kidney that are not supported by blood and not supported by oxygen anymore. Those areas don't work. As any area of any organ system in our body would respond, if you cut it off from blood flow and oxygen supply, this organ would not work anymore. That's why patients with atypical aHUS or any type of aHUS go into renal failure. Since those vessels are not perfused anymore, blood is not transported anymore, and everything that's subsequent downstream of this area is lacking blood and oxygen supply. What I just showed you is known for at least, it's known for more than half a century. And the first version of this disease that was really well described was the one that comes with diarrhea, right? That's the Walkerton disease. That's the toxin, so bacteria producing toxins circulating in your blood, and then producing those clots, right? That's how the Walkerton disease works. The toxins of those contaminated whatever water sources, or often it's beef, create a situation where those clots form in the kidney, right? And then you have typical aHUS, the mirror picture of atypical aHUS, and it's driven by the toxins of those bacteria. The difference between atypical and typical is when you're done with the infection and the toxins have left your body in the diarrhea-associated version, the disease can recover, and most of the patients go back to normal, and it doesn't come back again. Different from that, in atypical aHUS, the starting point is not a toxin, but it's a problem in your immune system, and we'll come to that in a moment. Those conditions do not go away, and with that you have an ongoing condition that makes you either constantly, producing this situation, or at least putting you at risk to having flares of this situation, right? That's one of the key differences between the two. In essence, from a what is the disease doing? What's the consequence of the disease? There's almost no difference, and that is a challenge for us establishing a diagnosis, and I'll come to that in a moment. Now, I said the typical, the diarrhea-associated form of the disease is known for more than half a century. This atypical form is known for, I'd say, 20 years now, probably a little longer, but that's when the literature starts talking about it. And the last 2 decades are really a period of an exploding body of knowledge and literature about this atypical form of aHUS. And just to illustrate that, and this is a link to the presentation of which I saw only the tail end when I came at about 9:30. The patient experience has changed dramatically with the gain in knowledge. So you will hear this afternoon about a patient that I had the pleasure to help management with, who was diagnosed before 1 year of age, and took a course of empirical treatment with winning periods and failing periods, not really knowing what the disease was, debating between was it a blood-driven disease or was it another problem that caused these recurrent episodes of what you just saw, renal failure caused by little blood clots, over 10 years. And then it took another 3 years, 4 years, till a specific medication or a specific treatment was available to this patient to really make a difference. Different from that experience, the most recent patient I diagnosed at Sick Kids, or we diagnosed as a nephrology team at Sick Kids, took from first presentation in eMERGE to establishing the diagnosis with finding the mutation and the antibodies 3 or 4 days, and treatment was established based on private insurance after 10 or 14 days. So this is the difference. So yes, it is on one side good to really stress that there is still a long way to go, but I think the change is already dramatic. Now granted, these were perfect circumstances under many aspects with this most recent patient experience, but I think things have come a long, long way. And one product of the development is this paper, which is just published a few weeks ago, that you should actually all have access to. I didn't bring it, but I can share it through whoever wants to be the contact person. That basically is a follow-up to the Aricetta paper that you all know, which established plasma treatment in 2009 as the standard of care for atypical aHUS. Now this is the follow-up paper for management of atypical aHUS with a focus on children, but it kind of goes through all age groups. It says in children, but it really makes statements that are applicable to both adult, pediatric and adult patients. And you have really an overview over all aspects of establishing diagnosis and management. I think nobody should talk about, and it's not since my name is there, or for my name there, it's for all the other real experts in the field who have present here something that should be really a backbone of conversations about what's the standard today. Okay, so what I've prepared, and I'm ready to move it around as you like, is I can talk a little bit, I wanted to talk a little bit about the mechanism of how the complement-mediated aHUS works. I want to give you a feeling that for the fact that as much as you feel this is a very rare diagnosis that affects only a very few, this is really now a spectrum of, it's considered a spectrum of complement-driven TMAs, and the number of specific diagnoses is growing. So I'll talk about that in a second. And then obviously make a special point, a particular point about atypical aHUS, and then the diagnosis. The first slide here is from the paper that I mentioned. Again, you don't need to take notes. You can either have my slides or you can refer back to the references. And this is from the paper that you will have, that I just showed you the title page of. So why am I showing this? I just said, the complement-mediated aHUS, you probably know about numbers 1 to 5 in a million, very rare disease. And where is it actually? Is here, is kind of that group that we are talking about. But today, and what a physician has to do when a patient comes through eMERGE is to think about this spectrum of potential differential diagnosis. And what we learn more and more is that complement does not only play here a role, but may have some sort of an impact in the other diagnosis as well. So this is not to confuse you. We will focus on this piece here. But what I want to say is that the patient comes in with what we call a thrombotic microangiopathy. So some sort of an organ failure and low red cell counts, low platelet counts. That's what we find in eMERGE. And then you have to go through this number of potential explanations for that, right? And that is one point that I want to hopefully in the QA session address with you. How can we, what's the vision for improving access to, the diagnostic tools and, establishing a network of experts that know how to do this quickly. Since I heard that several times, even this morning, it's about the quick establishing of the diagnosis and the quick access to the treatment. So how can we do that? All right, and out of this, big group of diagnoses that I have just shown you, this here, and I'm happy to share that paper as well with you. This here is now a list, the red highlighted part at least, a list of thrombotic microangiopathies, which in the literature are presented to have, or described to have benefited, at least in case reports, from complement targeting treatment, right? So there is a role for complement not only in the atypical aHUS, which is here in the second box at the bottom, but there's papers that show that complement plays a role in the Shiga toxin aHUS as well, and there's treatment benefit reports in the literature on that. There is literature that creates a link. You are taught at all times, you need to exclude ADAMTS13 levels and make sure it's not TTP. That's probably true, for a pragmatic approach to triage in an eMERGE. But at the same time, there is literature that link the TTP diagnosis to atypical aHUS. There is a biological link. There is successful treatment reports on complement targeting treatment in TMA associated with pregnancy, in patients post-stem cell transplantation, in patients with TMA after certain drugs. So again, I don't want to confuse you, but since the question was talk about stuff that's new, the new information for you is when we talk about complement-mediated aHUS, atypical aHUS, we have one diagnosis in mind. That's what you share yourself or your children. But the field recognizes that complement plays a role in other TMAs as well. And this is a growing spectrum at the moment. So now back to the basics of the atypical aHUS complement driven aHUS in the kind of the pure form as you have it in mind, and we want to focus on for today. So does anybody feel like saying a word, and this is not like playing a school teacher or something like that. I really want to make sure that you feel comfortable, since that's the other thing that I heard from you. Patients don't feel like being able to explain their disease, and I feel very sad about that, since that's a failure on our side. If we are not able to share what's going on with the patient, then we failed in that aspect big time as a group of physicians. So does anybody feel like talking about one line on what is complement? Does anybody know or wants to try? And again, this is not I'm a shy person myself, so no worries. Anybody, do you know what complement is or what it does? Try.
From what I've read and I understand, it's to turn on and off when it needs to attack a foreign object. Our system, from what I understand, is broken and the on and off switch doesn't work.
That's already a very great summary. That's fantastic. Really fantastic. So it's exactly what I'm trying to show with this slide here. So the complement system, you probably don't know that, is an ancient system in our body that's hundreds of millions of years old, and you find it in creatures that, some crabs, and throughout evolution you find complement as a system that obviously has played an important role, since otherwise it would not have been preserved that way. And the other thing that's interesting is it is through evolution very closely related to coagulation, to the clotting system. So complement and clotting are biologically married. So you're absolutely right. It is a system that's part of the immune system, and it's part of what we call innate immune system, as opposed to the adaptive or the acquired immune system. So the acquired immune system would be we're exposed to viruses or so, and we start producing antibodies against those. So it's a specific response that we have to develop. The innate immunity is a system that provides us with a first-line defense that's basically at all times available and present and active. And with that is a very important system, right? Since otherwise we would, without this type of defense mechanisms, we would be overwhelmed and not be on the surface of this planet if we could not defend ourselves against bacteria. So we need this, right? So we need to somehow recognize bacteria and get rid of them, viruses. We need to get rid of them and only allow the ones that we want to help us, for example, intestinal flora, and skin flora, but the bad ones that would be a threat for us, life threat, need to be identified and removed. And the complement system is our first line of defense. And what it does is it's working in a balance between activation and regulation, so activation and deactivation if you want. And it's designed to, as I said already, differentiate between foreign and self, since that's the key here. If you have a system that's at all times active and ready to jump, it needs to jump onto the right target and make sure, and control mechanisms need to make sure that it is not attacking the wrong target. And if this system either goes into overdrive or misses to spare the ones that need to be spared, should not be a target, then a problem happens. And that's basically the principle of atypical or complement-driven aHUS. That this balance between identifying the right ones, between activation and inactivation, is out of control, and all of a sudden the system is too active and it's not differentiating anymore between friend and foe. That's really what atypical aHUS or complement-driven aHUS is about. And I use this now not only for you, I use this picture for all audiences actually, since in a very simple context, it tells you exactly what complement-driven aHUS is. So you can find all components on this on this picture. So I spoke about the balance of powers, activation, regulation. That's the two groups of kids in a tug of war. As long as they're equal in strength, no group tips over. If one group becomes stronger or the other one loses a member, it tips over to the other side. And as you know, if you ever played this game, you know how important the surface is that you're standing on. If that is a slippery surface, and you don't find, you know, a firm stand, you slip, tip over, and then it tips to your side, you know, or you are pulled to the other side. You know, you lose basically. That is the cells on which that happens. That's the kidney endothelial, the vascular endothelial cells, going back to this little, you know, filter unit in the kidney, where I told you that you know, vessels go in, coil up, go out, and then I said the wall structure, that's where all this happens. Those cells are the ones on which the tug of war happens, and if the tug of war tips over for either defect on one or the other side, activation or regulation, or a problem with the surface happens, then you know you have the bad situation, right? So keep that in mind, since that's really telling the story. And then, of course, you can go into any level of craziness and detail and tell the same tug of war story with such a cartoon. That is the same story again. That is the complement system now in biologists' talk, where you have, on this slide, really the cascade, you know, starting points, the cascade of activation going from top to bottom. Steps in between, for the moment, are not so important. It's an activation cascade, right? That we're now looking into, again, into the kidney from now on a cartoon. That is basically the inside of one of those small blood vessels coiling up in the kidney glomeruli, in the filter units. I told you across the wall structure here, that's where the filtration happens, right? And that's even magnified here. So you have a layer of endothelial cells. That's the cells lining the blood vessels. And you have a wall structure called basement membrane. And then you have those cells sitting outside, the green cells, magnified here, called the podocytes. That's the urine side. So blood is filtered across this wall structure from here to go from blood to urine, okay? And on these cells here, those flat cells, called the endothelial cells, at the right side here, a little enhanced in size, that's the floor in which the tug of war happens, right? That's the cells, the endothelial cells. And on these cells, the two groups play tug of war. It's activation, that's the C3 becoming activated and going all the way to this end. Actually, it's only halfway shown here. There's a piece missing on that cartoon. Going all the way down, you know, from this molecule C3 that you have often heard in your clinical reports to what we call the membrane attack complex. That's the activation cascade. And the other team is the players that keep that in check, that hold it off, that allow it only from happening when it's needed and where it's needed. And that's the regulatory proteins. That's the factor H, that's the factor I. Don't try to place them all in detail. It doesn't matter. All I want you to remember is there's a group that works towards progression, and there's a group that tries to balance that off. So it's a balance that we're talking about. That's why the tug of war is so important. And it happens on these cells here. The bottom is just to, in another set of cartoons, showing how the defense players do their job, but we don't need to go into that for here. But this slide is now important. It's kind of a repeat of this here, right? The bottom one is a kind of repeat of the top right. It's busier, right? You can see that, it's busier. And now it goes, it starts again here, you know, the C3 is still here, starts still in the same way, but now it continues running to a place where you see that the endothelial cells are damaged. You know, there's they give parts, they allow exposure of the underlying surface, the basement membrane. They are injured in themselves, and you see all of a sudden that there is, in addition, platelets and neutrophils coming in and doing something. They form clots, right? So this is now the scenario where the tug of war is out of control. One team won. Either the offense players were, the attack players were too strong, or the defense was too weak for whatever reason. The cascade runs to its final step. Injury, that's the MAC here, that's the membrane attack complex. Those endothelial cells are hurt, they are injured, they break, and at that point, going back to our very first slide, the heavy blue and red happens. That's then those clots that form, okay? So if that's what if you can remember at least the backbone of of that sequence, then you have understood what atypical aHUS is and what complement's role in that context really means. And now, is there a question in that context? Who wants to show me now at which point eculizumab or Soliris works?
C5, complement 5.
Just show it. That's the pointer here.
As I know, it must be the C formula half, the complement formula half must be the Euro break to stop the complement, but it's at the
Just take your time. You find it.
I think it's C5 somewhere.
A little lower.
Okay, yeah, this one.
Yes, exactly.
So not yet.
And it's perfect. Thank you very much. That's exactly what it is. So at this point, a drug, eculizumab, an antibody that recognizes this molecule, stops that cascade from happening. So you're not changing the teams. You're not changing the surface in the tug of war picture. What you do is you basically bring somebody in with superpower and hold the rope and let it not move to one or the other side, even though the teams would be uneven in strength. That's what it does, right? It does not support one or the other side. It just holds the progression of, it prevents the next step from happening. And it does it on this level here. And the trick with this medication is it is smart in that way that it allows the complement system, which I introduced as a very important system, to remain active in that early part here, where we still need it. We want to be able to recognize bacteria or viruses. We want to have, be able to mount a fever when needed, since that complement system has components in it that kind of participate in an inflammatory response of our body. We want to remain able to do that, but we want to prevent that downstream, those downstream effects from happening. Please.
Sorry, I just wanted to ask a question. Does the drug work in a way, you say it stops it at that spot?
Yes.
Like in your explanation, grabbing it like a rope.
Yeah.
Does it act like a wall? Does it build
Yes.
up in your system? So
It's-
that if you take it over time, I imagine this great wall of China, being there so that there's no more progression.
Yes.
You still can be active and have your normal
Yeah.
movement of the C3 through the process, but then when it hits that spot, it hits a wall.
That's exactly what it is.
Okay.
Exactly right. And what is the consequence of that? There's one consequence that you should be educated about, especially if you take when you take the drug, if you take the drug. What is the consequence of this, what you just said, there's a wall and this part is just not happening. This downstream part here is not happening. There's a
meningitis.
Yes. That's exactly right. And do you know why?
No, honestly.
Perfect. It's not perfect, but it's great that you say so. So the reason for I said that the drug is smart in that it allows everything that is on the left side, upstream of the C5 step, still to be active and help with fighting bacteria and viruses, right? But there's parts of the cascade that are needed and can't be replaced. This MAC, this membrane attack complex, is needed to fight a certain group of bacteria. And we don't have much else to offer as a biological system to fight those bacteria. And that's the Neisseria that give you meningitis. And a couple other bacteria that are in the same group, like Haemophilus influenzae or pneumococci, strep pneumonia. So there's at least 3 bacteria. We're typically immunized against the HIB, the Haemophilus. The pneumococci are not that much of an issue. Some patients are immunized against them as well. But the Neisseria are the real threat, since they can give you life-threatening infections, sepsis, meningitis. And the reason for that is to fight those, the body needs the membrane attack complex. And if that is prevented from being available, and that's exactly what we just heard with the Wall of China, it's just not available anymore. And at no time, as long as you dose chronically and appropriately, then you have to do something to prevent it from happening. And the strategies are which? How do we prevent? We are vaccinating against many but not all strains, and that's why some recommendations, and this paper that I showed you does recommend that say on top of that you better take some chronic antibiotic prophylaxis, so antibiotics, penicillin for example.
Sorry, when you're on chronic antibiotics, though, doesn't your body develop
resistance or no? Some people don't tolerate all. Some people have allergies or intolerabilities to certain antibiotics, but that price is relatively small. So you can do that. Some patients have to do it. You have a car accident, your spleen is removed, then you're on penicillin prophylaxis anyway, for example. It's kind of a similar situation. All right. Any further questions in that context?
If we're not thinking about eculizumab, but like, for example, plasma or whatever, it kind of brings it somewhat under control, and then it can go up. What triggers that to go under control, and then the next time you're doing this, it doesn't go back under control?
I hope that I understand the question correctly. It's a very good question. So the alternative treatment strategy, or the old treatment strategy, was plasma, either in form of infusion or exchange. And the way that works, you can apply the same explanation of the complement system and how aHUS works. In that context as well, you, with the plasma infusion of a healthy donor, you replace or you infuse, basically you strengthen, take the tug of war, take the tug of war image, and now you, I spoke about, the stronger offense or the weaker defense. With the plasma infusion, you strengthen the defense team. You're infusing, you're adding players to the defense team. That's what the plasma infusion does. With the plasma exchange, you do that on one side, but as well, you remove the weak members of the teams, on both sides actually. So you get rid of the ones who cause a problem, and you replace them by good players, and you re-establish the balance. So you can really use the tug of war picture for that as well.
Then those weak players, the body could make more weak players.
Exactly. So they have a half-life. The the substitutes have a half-life, and you have to continuously do that since they disappear over time and the body takes over again with the bad players. That's exactly what it is. That's why you need to, and the typical, and again, you will hear in the afternoon, the patient you will hear about experienced basically, the titration of how long you can go before you need to bring another group of substitutes in, which is give or take 14 days. So it's somewhere between 10 and 14 days that you need to infuse again. Since at that point you will lose the good players and you will, the balance will tip over to the bad players again.
Based on that explanation, is this why when we speak with government that they believe that that is a good treatment?
Yes, that's exactly what it is.
So what is the difference between having the drug and having this?
The difference is that the medical treatment, which at the moment is eculizumab, in the future there will be others, will be way more efficient and you can control it much better. Plasma treatment is only it works in some patients, it doesn't work in others. In some patients it works to some degree, but it is not capable of stopping the entire or holding the entire problem, dealing with the entire problem. So it is in terms of treatment strategy not bad, but in terms of application we know that it doesn't work in all patients. And it is compared to the medical treatment that's very specific and designed to work right at that spot where it's needed, and you can titrate it and you can measure the effect. It's just the weaker treatment. That's really what it is.
Because when I try to explain it to people, and I might be wrong in my explanation, I equate it to having a leak, an oil leak in a car, and filling it up, like topping it up
Yeah,
with oil.
I avoided that kind of analogy. The reason for that is even the antibody eculizumab has a half-life. So even that player needs to be replaced after 14 days again. So that's why I was not using that argument. It is just, you have a concept that definitely works. It's designed to do exactly that job, and you know that it is working, and you can titrate it, and you have specific ways to monitor its effect, versus you have some not as targeted, precise measure that by concept works in a similar way, but it's just not as efficient as the eculizumab. But both have a half-life, so none of them is a definitive treatment.
I don't know a whole lot about this. I just wanted to ask if you do the blood exchange and you do it every 10 to 14 days, and again you were saying that it's not as exact or perfect. It's as good as it can be.
Yeah.
Is there the way I looked at your picture, your cartoon, is there damage done to the cells of the kidneys when you
question.
When you wait to do that, as opposed to if you were on the drug where they're stopping damage from happening?
Very, very good question. So with the with the plasma treatment being the weaker treatment, if you want, for lack of a better word, you allow this disease to be in a subclinical way active. Probably in at least a good subgroup of patients. This is now a little bit of an assumption, but I think my community would agree on that, that there is chronic disease activity. And again, the patient you will hear about this afternoon, this patient's course will speak to that, that even though you control the tip of the iceberg, like the red blood cell problem, the platelet problem, the anemia and the thrombocytopenia, you accumulate chronic kidney damage, which presents itself then at some point as hypertension and loss of kidney function. At some point, the kidney reserve is consumed, and then it manifests as this patient manifests with renal failure. So that is another very strong argument to going with the most efficient treatment, since even though you may mask the surface, the most obvious, symptoms, in the long run you run the risk, and that's documented, you run the risk of accumulating damage and eventually losing kidney function. I think you first, and then Mary Jane.
At what point does the complement system start to not differentiate between good and bad? Is it prior to that, when you put eculizumab, is that a key point, or is it right at that point?
So that's an excellent question. The differentiation between friend and foe is by presence of regulators. So the activation site, the offense team, is present at all times and does not distinguish between whatever surface there is. You're a bacteria or you're an endothelial cell of a kidney vessel, you're attacked by the complement system. As a blood vessel cell of a body, you have helpers, you have the defense players on your side. You don't have that as a bacteria. That's why the bacteria is killed, and under normal circumstances, the blood vessel cell not. So the spot where eculizumab works is past the first step of attack, if you want. That was your specific question. So it's past the first step of attack, it's, as I said, it's strengthening basically the otherwise naturally available defense. Does it answer the question?
Yes.
So who wants to help me to design the next generation of eculizumab? I mean, the next, another eculizumab. Where would you interfere with the system?
Well, I would interfere at the end, at the part where the problem, well, after the MAC, to have the MAC,
Yeah.
so somewhere there. The question, something to understand, it's like the eculizumab, it's not stopping the source of problem, it's stopping the consequences.
Yes, exactly.
So that's why we have the first part, which is helping the body to fight with the other microbes, bacteria, and all the things.
Very good.
So
I just take other bets, and then I'll tell you. Where would you design another drug? If you had superpower and no cost involved, what would you do to have the same benefit? You just say it in your words. I can translate it for you. You can try again.
I'm not sure if I will understood correctly. I know the complement formula aHUS, the antibodies, which destroy the formula aHUS, they are the reason why the cascade starts. So I will control that thing.
So he is referring to factor H being an important helper to control. You see it actually here. Again, I don't want to go into the details of the cartoon, since otherwise that's the rest of the day. But factor H is an important player on the defense side, and factor H can be either absent through mutation, it can be mutant, or it can be impaired in its function by the presence of antibodies. Absolutely right. So how would you like to overcome this?
Well, I'm not a specialist, but I think
You're sounding very good at it.
as a concerned father, to fight with the function of the factor H, not to stop, not to interact with the cascade, and to do his job.
But how would you do it? Just say it in your words. Of course, that's what we want. We want to overcome this problem.
You
But
get an injection of factor H.
Well,
yeah. So that is one way to think about it. You know, you just overrun the presence of these antibodies by flushing the system with factor H. Another way would obviously be to remove those antibodies.
The memory of the plasma thing? Or
Yeah, we don't need to go into how you do it. That's my job then in a moment. But so the concept would be either, you know, flush the system, strengthen the defense by giving it, you know, tons of factor H to overcome the enabling, you know, presence of the antibodies, or remove those antibodies. You know, take the bad boys out, right? Okay, so we have two concepts already. Strengthening the defense, or you know, blocking the cascade at a different spot. Which other spot came to mind? Where else would you like to block? Mm-hmm.
I have no idea if it's right or wrong. Does it all start at C3?
Yeah.
That's where I would go.
Okay. This drug is called comstatin. And is designed by Joe Lambris in Philadelphia, and is already under quite a bit of development, and is published, and is working very good, very well, is doing a good job. The problem with the drug is that it is not only blocking the cascade here, it's also preventing those good steps upstream. So there's a little bit of an issue with it. But this drug is in development. So and it has a name already, it's comstatin.
And what is that?
It's an antibody against C3.
Is it an injection and pill? Because that's...
Honestly, I don't know.
What's the doctor's name?
Lambris, Joe Lambris, it's a Greek researcher, fantastic complementologist, and he is working out of Philadelphia.
what would be the complement for the things we are missing after the... What would be what we would add to have the complement system in our body? Control the other bacteria and...
That's where you know, research is, and clinical trials will be needed. An answer to your question is you probably won't overcome this issue. You can't just replace it. You can't just shut down the entire cascade, but you could titrate it. You could probably modulate it to a point where, you know, you have enough you know, complement active to do the good job, but prevent, you know, the problem from happening. So it could be a titration effect. So one drug already. Factor H, there is Behring, a German company, and CFL, blah, blah, blah. There's a French company that both, and that is not a promise. These companies have worked on purifying factor H, and they have, at least at the moment, stopped working on it. But this was exactly as you pointed out yourself now, you know, recognized as a strategy to you know, treat, and those companies have worked on those on purification of factor H to flush the system. Strategies to remove the antibodies, that's either drugs that suppress the white cells that produce antibodies, so that's rituximab or Cellcept, MMF, or plasma exchange treatment. So it's that is the strategy that we can offer today. Come to that in a moment.
Why did they stop in France and whatever?
It's very easy. I have worked with Behring quite a bit. They didn't see a business case. It was just not enough in there for them. Yeah.
Generate a bigger clientele.
Yes. Another compound that is published about, by far not a drug yet, not at the level where it, you know, but at a stage where it can be tested for safety in patients, is called Aurin, A-U-R-I-N. And that is doing what the gentleman said. He was wishing for a drug that stopped the cascade at the MAC stage, that's working there, and working at the factor, oh God, where is it? Here, factor B level, B B is here. Since you see that B and the little ones, the little siblings of B, are part of the progression of this cascade, but without the factor B, the cascade would not run, right? So this drug, Orin, out of BC, it's a biochemist from BC, I think a biochemist from BC, or pharmacologist from BC, is working and has published, there's literature, that's why it's not a secret, I can talk about it, is working on a drug that binds here and here. So there's an alternative. And then Omeras is, to the best of my knowledge, also working on the B level. So it's basically a player that works in this, at this point. So it's a little upstream of the C5 activation. And it's all doing the same. You know, what I want to share with you is, I want you to understand the concept, and I want to understand you that there's a principle of how to treat, and there's one player at the moment which is doing a great job, but there's alternatives to that, and the alternatives will come. Right now, it's a China wall here, wall of China here, but there's other players, and there might even be smarter ways to interfere, since you will be able to modulate more based on the individual needs of a patient. Please.
So we're talking about blocking or controlling progression.
Yeah.
What is cure?
Well, do you want to try and answer yourself?
No. I think it's genetic implantation of whatever is missing.
Yeah. So I think the truth here is, at least for the lifetime of all of us and your children, there is no cure. There is no cure. There is ways to have more permanent fixes, more permanent treatments that allow you and your children to have an almost normal life. And you're witnesses to those effects yourself, at least some of you. But it would be misleading if I stated that there's a cure. Eculizumab is not a cure. It is a treatment that is, as you said yourself, preventing the effects of an otherwise ongoingly impaired system. Any of the treatments that I mentioned in development are equal to that. None of them is better. They may be more or less, efficient in what they're doing, but they are not, by concept, they are not different. There's one situation that is that people refer to a cure, but I refuse to accept that. When you talk about a liver transplant or combined liver-kidney transplant, with that basically replacing the site of production of impaired proteins, that impaired players in the system. Factor H mutations would come from a liver that produces ongoingly factor H that's mutant and causing problems. So you could argue, I just give you a new liver, or you receive a new liver, and with that, that's a cure. With the little side effect that you're now a liver transplant carrier on immunosuppression, if this liver fails, you either die or you have another transplant. And you're having that only after massive surgery. So this is just misleading to call this a cure. It's just, in my mind, it's just wrong. It is obviously a more permanent treatment, since then you're not on a complement controlling drug anymore, but you're on immunosuppressants. This is you don't get it at no cost. Pardon?
You're trading one thing for another.
And even
And you're always trading for the unknown.
right, and from a kidney point of view, the cleanest solution is a transplant in a situation where you have the problem sitting on, it's shown here, this little kind of MCP molecule here, the 4 spheres on a little stick, stands for defense players that are anchored to the surface of cells. And if a mutation at that spot would be the cause for the disease, of course a new kidney would come with a good MCP, with a normal MCP. So now you most likely don't need to be worried about loss of complement control anymore, since your MCP is normal. But you carry a kidney transplant, and that in itself has a half-life. This is not forever. Best case scenario, 25 years, but then you need another one. And
does it also mean that if you have the wall of China, let's say, you can't stop taking it, or it's all going to start again?
Yeah, that's another very good question. And with that, by the way, we're not moving through the slides, but we're basically doing the job of what the slides were meant to be doing. So I think we're good. You're touching on the question of duration of treatment.
Right.
And with that, you're asking another question, which is which you haven't spoken out, but it's implicit. In starting point of a patient career, why does it start at some points and not in others ever, and so on. So duration of treatment, in principle, I would agree with you. Treatment for this condition is chronic and lifelong. At the same time, so that's a principle, kind of a generic statement based on principle, since and it's consistent with what I just said. You're not getting rid of the condition.
Right.
At the same time, we know that there is situations where you have more or less risk of either chronic ongoing disease activity, and more or less risk of relapses to happen. So you have high and low risk categories within this same scenario. So not all conditions are considered to be the same risk. And the best we have to offer at the moment is that we can single out 1 or 2 conditions where we feel that the risk is relatively low, and with the appropriate monitoring, treatment can probably be discontinued. Even though you're not getting rid of the condition, but you can discontinue the treatment, and you just follow the patient very carefully, and you have to follow yourself very carefully. And those conditions are MCP mutations. After transplant, that would be considered a situation where you can stop complement specific treatment, and antibody-mediated aHUS, where the antibody titers are very low. But you will not get rid of the condition itself, and with that, the need to be followed. Does it answer your question? You had another question.
The different treatments that they are in development, I understand we are not discussing the efficiency. We discussed the price maybe for the medicamentation, or
The price of which?
well, you were saying that there are different ways to stop
Yes.
the effect, but we were discussing not of the curing. We discussed just maybe different types of stopping it and maybe the price. Because Soliris
I agree. I agree. Yeah, I agree.
So we're discussing just that, not curing, nothing more.
I would agree. I think for yeah.
Because the problem in Canada now is the price. It's expensive, the Soliris,
Right.
I would say.
Yeah.
So that's the only thing that you.
I mean, again, what I wanted to do is I wanted to contribute an educational element to make you think about and make you understand, you know, what's available at the moment and what's coming, and how these, you know, new drugs are designed, and you know what the idea behind is. And I'm not commenting at all deliberately at this point on access to any of those drugs, timelines, and strategies to do the politics around it. So that's a whole different discussion that I just, you know, neglected for the sake of doing the science and the medical piece to it. We can talk about that as well, but I would suggest that we do that maybe at the end, and leave that kind of, you know, more to the medical and science aspects.
Can I just verify what you said about treatment on or off? If a patient has had a kidney transplant and they're not indicated for the drug, that's because the medical team is monitoring, determining that the risk is low at this particular time. But they could be indicated for the drug at some future time.
Yes, that's kind of the way to summarize it. I can refer to this slide here, which is from the paper that I showed you in the beginning. It's fine print, but we can take a moment to go through. So this is basically the international recommendation how to manage transplant scenarios. What you see here is basically you know, a breakdown into two scenarios. One is a living-related donor scenario. The other one is a deceased donor scenario. And then at the bottom part, it's comments on how to, you know, limit the risk of concurrent management, providing an additional risk to the precipitation of a TMA at any point or under any circumstances, right? So let's not go there for the moment. So the bottom third, we just ignore for the moment. We'll focus on the top two systems. And I agree, it could have been done a bit, you know, better, but the information that's on there is really good. Okay, so if you you know, consider a deceased donor or a non-related living donor, then a transplant is possible, which is already a statement that's very, very important. A transplant is possible as long as you have access to treatment that controls complement activation. That's number one. Number two now is, if you look into a living donor situation, you know, with a related donor, then you have basically three categories. One category is, and the principle here is now to consider the risk not to the recipient. The recipient will always have to, is always in the first system here. You need access to complement controlling medication with a very few exceptions. So that's the side of the recipient. But the donor is not a problem in a living related situation. Since, you know, in that scenario, you consider what is the potential risk for those two individuals, biologically related individuals, to share the same disease-causing condition, right? And now you can differentiate between those three levels. You have either a situation where the mutation that is identified in the recipient, so the patient, is clearly linked to disease. You have screened the donor. The donor doesn't have this mutation. With that, even though a kidney is donated and the donor goes through stress and all that, there's a safe way to donate a kidney to this recipient, and then the recipient just needs to be managed. As I said, that's the top line. But you can use this living-related donor as a donor, right, without additional risk. The second category is the donor shares the same mutation, but hasn't, identified him or herself as a patient yet. In that scenario, it's at the moment excluded. It's strongly recommended to not go for a living donation in this scenario. And from a risk assessment point of view, called intermediate, but with the same consequence, don't do it. The scenario would be looked at. You don't find a mutation in the recipient, so you don't know what is really behind the disease, or you find a mutation that is not exactly clear in its function, in its impact, and with that you're basically in the gray zone for the donor, and to be on the safe side, you exclude this donor as well. So you have basically only one scenario where the community at the moment would say it's safe to go with a living donation, which is living-related donation, which is what the mutation is that causes, or the condition that causes the disease in the recipient. You exclude that in the donor, and then you go for it. If you talk about a deceased donor scenario, then it's about the risk assessment in the recipient, right? Now the donor is the donor, and we assume that the donor is healthy, has biologically nothing to do, so you don't have to consider aHUS in that person, and you wouldn't even know who that is. Not even the physicians would have much information, but you would not have to consider aHUS in that donor. Now it's about the risk of the recipient to have a disease recurrence or not. And again, there is 3 categories: high, intermediate, and low risk, defined by now the type of mutation that is found or not. So if you find a factor H, a C3, or a factor B mutation, or certain, there's poor graft, there's another scenario that's defined, but that's the mutations that are called high risk. Then you definitely have to consider this patient or this recipient being at high risk for recurrence, and you need, as per current standards, specific treatment, at the moment eculizumab, for the recipient. If you have a factor I mutation or an MCP mutation plus something else called a combined mutation, you're in an intermediate risk category, and you probably are best off at the moment with eculizumab. An alternative, if you didn't have access to it, would be plasma exchange. And mind you, at a sensitive point, this flowchart is stopping sharing recommendations, which is the duration of those managements. If you, however, have either an isolated MCP, no mutation, low antibody titers, or what's the newest mutation, a DGKE mutation, the consensus feels there is no prophylaxis needed, and you would only monitor those patients and watch for recurrent events. Personally, I kind of disagree with the no identified mutation. I find this is too hot in my mind. My deferring, even though I'm a co-author on this paper, and I can live with that, but if it was my practice, and if I had access, I would recommend to place the no identified mutation patient into the intermediate risk category and treat for 6 months, and then stop management and then monitor after that, since the 6 months period is probably the highest risk for recurrence window. So that's the only different opinion that I would kind of want to share with you at this point. So that's what's currently the current standard for the management of both the recipient and the donor in a transplant situation. And the jury, there is some comments in the paper to treatment duration. The jury is out. We don't know what treatment duration to recommend. And the paper says it several times. You know, it's urgent to do research on that, and to, you know, there's some thinking about it. The best, the most honest way to share, you know, what the thinking about the risk scenarios is this kind of those 3 boxes that really tell you, you know, what the community thinks about where do you live with high risk, intermediate, or low risk, and that I'm taking the liberty now to anticipate what's coming up is most likely a recommendation that in the top box you will find a recommendation for chronic lifelong treatment. In the lower 2 boxes you will find some sort of a temporary treatment recommendation and you know, some sort of a trial then to discontinue and monitor closely and educate the patient to watch for symptoms.
This is a scenario based on a transplant of a patient that's presently on mechanism?
Regardless.
Regardless. Does the group have an opinion on whether the kidney transplant patient should be on the drug pre-surgery?
Well, that's a very good question, and I think the answer is relatively easy. I think there's dosing protocols that would recommend in a scheduled transplant situation where you have a living donor, you would probably treat at week -1 and then -24 hours, and then on the day of transplant, and then subsequent to that. So yes, you would treat some sort of a, you know, lead up to schedule. If you are in a deceased donor scenario, you don't have that time, since, you know, you have a window of 24 hours, 36 hours to, you know, use the transplant organ. In that case, you would probably start as soon as you could. So maybe 1 dose before going to OR, and then kind of have an intense induction right afterwards. And then continuing based on those risk stratifications. In the only extra comment, and again the patient presented this afternoon will speak to that, you know, there is a few patients, but it's the exceptional patients who need, despite end-stage renal failure and dialysis treatment, ongoing management of their atypical aHUS, since otherwise, A, they would feel in general unwell and would have extrarenal symptoms, if you want, or specifically have low red cell counts or platelet counts. So there's patients who are in need. The teaching is still that the disease burns out, and at the point where the kidneys are gone, you don't need specific treatment. I think we have learned a lot about you know, the subtleties of this recommendation that's probably not really true. I think in the end of the day, probably everybody would benefit despite end-stage kidney disease, but there are certainly patients in whom it's indicated, and that's the ones where the red cells and the hemolysis and the platelet consumption is not stopping despite renal failure. Yeah.
Are concerned about not being able to be listed even because government and interim funding suggests that they should be on the drug, but government will not fund it pre-transplant.
Yeah.
So
we have worked through those scenarios, and it's true there's I think the cleanest way to negotiate that is to make this case here, you know, to define the needs around transplant. And I think Dr. Gutschib, as far as I heard from you guys, has spoken about that. At the same time, I think it's scientifically not clean to pretend that there is no medical need, or to exclude the potential for a medical need of treatment while you're on dialysis. And in those patients, I would always try to go for establishing the treatment as soon as possible on dialysis, and then you're prepared at all times to receive your transplant.
Just a question.
Sure.
Is there a timeline to how long the kidney can handle the plasma infusion before it leads to like hypertension or other consequences? Is it based on like the number of transfusions you have, or is the risk higher in children versus adults?
It's an excellent question. Part of the answer is, the honest answer is I don't know. I can't give you real firm treatment durations. But again, a couple concepts. So with my earlier statement that plasma treatment is not as good as, for example, the C5 antibody treatment, you must assume that despite optimized plasma treatment, you will have disease that is progressing, and then they have to go to others more involved and more expensive plasma forms. So it's fresh frozen plasma versus the pooled plasma, which is sold as Octaplas, which is less of a sensitization and allergy risk. And the third is there is some patients who just don't tolerate, despite normal urine production, the volume that they're infused. And that might be a bigger problem in children. And in those patients, the blood pressure becomes an issue. So you have a patient who is under the volume challenge, the infusion of plasma, producing high blood pressure levels. So that's just a number of problems around the limitations of plasma treatment. All right, I wanted to share, we have spoken about most of the points, and that's exactly the way I wanted to do it. I just wanted to show you this slide here. So we have spoken about the management of transplant patients. And now I want to show you the slide, and again it's from the same paper, that refers to how patients with antibodies are managed, right? And the difference between all the other scenarios where you have mutations that have an impact on one of the tug-of-war teams, the antibodies are basically another factor, or an antibody that's produced by the body at some point for unknown reasons to impair a key defense player, factor H. And with that, you have another treatment option in those patients. And this treatment option is to address the antibodies. So if you think lupus patients, if you think autoimmune thrombocytopenia, or many other antibody-driven diseases, ANCA vasculitis, Moritz Wegner, you may have heard of those diseases. Those diseases are driven by antibodies, right? And we would, in those, till today at least, in those patients, we would never think of complement-specific treatments. We would think plasma exchange, we would think prednisone, we would think IVIG, so infuse immunoglobulins, we would think rituximab, Cellcept, and that's the options that, or cyclophosphamide, so immunosuppressants. And that is what I want you to understand in this context. So in patients with antibody-mediated aHUS, you have alternative treatment strategies. You have not only block complement, but you have also remove or suppress antibodies as a treatment concept. And that's in this tree here. So the tree just tries to follow how a patient is managed in real life. you present with aHUS, and ideally you start with a specific treatment as quickly as possible, and then only subsequent to that you find out about the antibodies as opposed to a mutation. And now the tree differentiates between a mild course and a severe course. In the severe course, it talks about combining all these treatment efforts, the complement-specific and the antibody-targeted strategies. In the milder courses, and let's forget about the details. There is a thought that you could switch from complement-specific treatment to antibody reducing or removing treatment strategies. And this is another strategy that will be discussed in context of treatment duration, conversations. Since here you have, and treatment duration is really eculizumab duration, use of eculizumab. Time, you have the possibility to limit the use of eculizumab, let's say to use it for the first 3 to 6 months, and that's a paper that I published myself. Recommend that. Establish the patient in safe conditions, block all the complement-mediated damage, since you know that eculizumab can do that, and then introduce at the tail end a strategy that addresses the cause, the underlying cause, which is the antibodies, and monitor the titer of those antibodies, the level of those antibodies, and under ongoing sequential monitoring, you introduce the treatment strategies that reduce those antibody titers, and if they are down, you're probably safe to remove or to stop the eculizumab. At the moment, I would not recommend this treatment strategy if you did not have ready access to re-establish the patient on eculizumab. And that is the big problem, with our fragile funding system, that this is not given at the moment, at least geographically here. But in another system where we had this, where that would, or hopefully in the future when this is available, I think that's the most reasonable way to deal with antibody-mediated aHUS. And the very last slide, and then I'm really stopping. So again, from this paper, which you will have, everything we have done now, introduce the disease, understand what is at the core of the disease, see how that translates into treatment strategies with the two specific treatment scenarios of a transplant situation and the antibody-mediated aHUS. This loops back to, how do you establish this diagnosis? How do you really confirm that that's what you're dealing with? Basically to the beginning of a patient's career. And you have seen those, I think Alexion has designed some time ago something that many talks have used by now, this kind of algorithm where you exclude Shiga toxin aHUS, you exclude TTP, and then you're basically left with atypical aHUS, and that comes with certain specific lab values. In all honesty, even this paper, even though it looks different from this cartoon that you're used to, maybe the left column here is not doing much more than exactly what I just said. It introduces, in addition, the infections, strep pneumonia-related aHUS, and maybe some viral infections, the H1N1 or influenza-mediated aHUSs, but it still hinges on exclusion of TTP, exclusion of Shiga toxin-mediated aHUS, and it also, mentions, since we're pediatricians, metabolic disorders, so the cobalamin C deficiency, but it's still more or less the same train of thoughts and backbone of establishing a diagnosis. The statement that I want to make here is not to say we're not better than we were a little while ago, still true as well, in that aspect. The statement I want to make with this slide is, I think part of our efforts here, and I hope for your support here, and I'm hoping for more conversations maybe over at lunch, is we should work not only towards treatment, we should also work towards a structure of establishing the tools to diagnose the disease in Canada. And this is not, I guess Toronto takes a certain lead here, but this is not like an ego trip, about our institution. This is about a generic need and an unmet need. And in fact, we won't become better if we don't have a centralized place where, in a timely fashion, in a situation where clinical workup and research are linked, and the clinical insights, into how to manage a patient is also present in not only a one-man show, but in a network of experts, from where you can also offer training to other places. If we don't work towards that. So you can call this a center of excellence or a referral center or whatever, but I would pledge and I would ask your support to put that onto your agenda. I think this would be an important next step to move this field forward and to make a difference here for Canada. And it will strengthen in all context of negotiating, your requests, your pledges, and being a partner to an industry partner or to the government. If you can say, or we can say as a community, we have done everything to really identify the patients who need this drug, or a drug, any drug. And for how long, since we have the tools at hand to diagnose and to monitor outcomes, we will be in a much better situation. So this is really my conclusion here. I think this is for Canada, and done in some parts of the world, but not in all. So for the rest of the community as well, this is the next step that we should take. Thank you for your attention.
Thank you.